illustrious group of panelists. So kind of like what we did with our virtual series last year, where we have a group of panelists. Everyone's going to speak on the topic for about 10 to 15 minutes apiece, and then we'll open it up for questions. We'll be pulling questions from the chat, or if someone wants to raise their hand and, ask their question verbally, both are fine. I also want to give a big thank you to the Health Equity and Antiracism Committee, especially the co-chairs, Dr. Adrienne Adams and Dr. Josh Elo, for helping us with conceptualizing this and locating panelists and just everything. And Dr. Adams herself is hopefully going to be moderating at least one of these upcoming sessions too. So looking forward to that. So before we get started, I'm just going to introduce our panelists for the night. I'll go in the order that they're going to present. They're all going to be speaking about different aspects of the core topic of bias and cultural and structural humility. So first up, we'll have Dr. Sheila Caldwell, who is the SIUS Vice President of Antiracism, Diversity, Equity, and Inclusion, and the Chief Diversity Officer. Then we'll have Dr. Danielle Hairston, who's the President of the APA Black Caucus and is a Psychiatry Residency Program Director at Howard University. Then we've got Dr. Kemia Sarraf, who is SIUS Adjunct Assistant Professor in the Office of Equity, Diversity, and Inclusion. And then wrapping us up will be Dr. Cheryl Wills, who is the Chairperson of the APA Presidential Task Force on Structural Racism, a member of the APA Board of Trustees, and an Associate Professor of Psychiatry at Case Western. So I'm going to quit talking so that we can actually, get to our presentation piece. Dr. Caldwell.
Thank you so much for having me, and thanks to all the participants who joined today. Actually, I thought it would be worthwhile to just actually start off with some key definitions that may help inform our conversation. And I will be taking my definitions from a psychiatrist, Dr. Frances Cress Welsing. And one of the ways she defined structural racism is an oppressive system embedded in patterns of thought, speech, behaviors, and emotional responses that produces and reproduces enduring racial inequities in education, economics, healthcare, entertainment, politics, religion, sex, and war. And so basically, when you look at all of those meaningful activities that all humans engage in, she basically speaks to how structural racism is embedded in all of those particular patterns and all those meaningful activities in life. And if we was to contrast that with structural humility, I would actually define that pretty much in the opposite. And I would start out by saying structural humility is a practice of reflection, not on the individual, but on systems, policies, and practices that maintains and expands patterns of thought, speech, behaviors, and emotional responses that reproduces inequities in education, economics, healthcare, entertainment, politics, religion, sex, and war. So when we think about what structural humility requires, it really requires the individual to start from broad to narrow. Oftentimes when we engage in these conversations, we sometimes get polarized because if we start with us, we'll think, well, how am I being racist, or how did I maintain system structures and policies that continue to create, maintain, and expand inequities and racism? But structural humility basically requires us to start with the structure, which means that we need to look at the specific systems that I just mentioned, all of the major activities in life. So how does structural racism impact education? It invites us to be more curious and certain. How does structural racism impact economics and healthcare, which is what we're actually speaking of today, and politics and religion and war? And then we need to apply a structural lens to understand those specific inequities in those areas. And we are not looking at individuals or cultures or their deficits, but we are looking at a system. We're not saying that people are the problem. We're saying that the system is the problem, and that we actually need to examine the system, and then we need to dismantle the system as we find areas of inequities that hinder human thriving. And we also need to understand, as we reflect on the system, that these systems were erected before all of us came to be, that they have been enduring and lasting for centuries. And although I would say, to quote Isabel Wilkerson, that we did not create these systems, all of us at this point have the responsibility and the ownership to look at these structures and think about what our part is and our power and our influence to create a more equitable, just, and vibrant society for all. So one of the things I would like to do, I think, to make it a little bit more clear, and I think in some ways this is personal for me, part of this example. My father, Elijah Maggette Sr., actually passed away in 2017. And one of the things I did prior to his death, even though I didn't know he was going to pass away at the time, was I conducted an oral storytelling project. And he talked about his time growing up as a young boy in Mississippi. So one of the things I want you all to think about, he was actually born in 1933. And I think about Brown versus Board of Ed that abolished separate but equal in 1954. So essentially he spent his entire childhood in a system that was separate but unequal, because he was 21 years old when they actually outlawed separate but equal, which was Plessy versus Ferguson. And that law started in 1896 and it lasted until 1954. So we're looking at 58 years of a structure that basically legalized, I would say, inferiority. It legalized bias, it legalized stereotypes, it legalized microaggressions. It basically told white citizens that this was okay, and it also put people of color, specifically African Americans, in a specific place. And if we talk about that particular law, it came about in 1892. Homer Plessy, who was 7/8 white and 1/8 African American. And I think it's very interesting that he was very aware of those ratios back then. And it was very deliberate that he decided to go sit on a train in Louisiana that said for whites only. He did that on purpose with the intent to be arrested, with the intent to challenge the law. And so this law
Dr. Caldwell, you went to mute somehow.
Okay, I'm very sorry about that. Can everyone hear me now? Okay, thank you. I apologize about that. One of the things that I think people may not know about this law, if you really unpack it and dissect it further, when the justice actually talked about this law, he said, well, when we abolished slavery and we allowed African Americans to be free, and at that time, the Negro, he said, we never intended, this is actually in the law, we had never intended for you to be equal to white men in society. So when you hear the word social justice, society, this law specifically said we never intended for you to have the full freedoms and the rights of white people in society. So that particular declaration is considered one of the worst laws that was ever created. I can think of some others, but according to the Supreme Court, it was one of the worst laws that was ever enacted in American history. So this separate but equal doctrine gave constitutional sanction to laws designed to achieve racial segregation. The separate but equal doctrine introduced by the decision basically was overruled in the US Supreme decision in Brown versus the Board of Ed. So I just want to give you some examples. This law basically made way for Jim Crow laws and Jim Crow etiquette. So when you think about Jim Crow laws, just a few examples that we're all aware of, and many of us have seen the pictures. You couldn't drink from the same water fountain. You couldn't sit next to a white person if you were a Black person in a movie theater. Some of these laws also extended to Latin and Hispanic people of descent, as well as Jews. You would see signs that say no Jews, no N-word, and no dogs. I mean, that was literally, they would group those together because they wanted to make it clear how they perceived us. Animals, Jews, and African Americans were all in that same category. Jim Crow etiquette: a Black man cannot offer his hand to shake hands with a white male because it implied being socially equal. Again, socially equal. You were not conferred titles of respect. I think I'm recently watching Emmett Till, and I remember when the counsel was briefing her, he said, I'm going to call you Mamie, your first name, but you're going to refer to me as sir, because that is how the law is. You get called by your first name, but it's you will call me sir as a white man. It was actually illegal to confer titles of respect upon African Americans. If a white person and a Black person rode in a car together, the Black person rode in the back of the car, or if it was a truck, they literally had to get in the back of the truck where it might not even be a appropriate seat, because they wanted to make the distinction that maybe we'll allow you to vote and you no longer are required to be a slave, but we want markers in society to show that in every point you will be inferior to a white person. And so if we think about just that one example, the law, Plessy versus Ferguson, giving way to Jim Crow laws and then Jim Crow etiquette, social norms and customs. None of us was here when that law was created, or I would even say some of us may have been here when it was abolished. But no individual white person on their own created their structure, that particular structure. It was the Supreme Court, the highest court in the land, said this is legal. And then you had other people who followed suit. So structural humility would not ask us to get defensive and say that I didn't live during that time and neither did you. Why am I being held accountable for that? I think a lot of times that could be a defensive response and reaction. Some people may ask, well, that was, years ago. What does that have to do with modern day times and even modern day injustices? So structural humility will tell the story of why African-American males are incarcerated at much higher rates in the South than white men because of Jim Crow. If we were specifically to look in California, the dominant caste group would be Latinx and Hispanic males. Structural humility would invite us to examine why white students in this country receive $1 billion, and I will repeat that, $1 billion more in public funding than African-American kids. And then that might explain why African-American kids and students are trailing behind white students in every meaningful marker in elementary school, reading, in high school, when we look specifically at math scores, in higher education where I work, when we look at how they are retained, how they are promoted, how they complete college. Jim Crow and structural humility would invite us to examine that more deeply. When we think about entertainment and the media, we were asked why the South used movies like Birth of a Nation to craft a narrative that would disadvantage African Americans and instill fear and paranoia in whites. And while we still see media images today that distort the dignity of African Americans, people of color, the LGBTQI community, structural humility would ask us to examine those issues deeper. In healthcare, structural humility would ask us to ponder why more African Americans, Native Americans, specifically the Navajo Nation and Hispanic and Latin Americans have died of COVID at alarming rates, double the rates of their population and representation in America. And it's not because of genetics, as some people even learn in medical school, but it's specifically because of their limit to access and representation in healthcare. It would also ask in healthcare, a recent study, why African-American males' suicide rates have increased by 59% over the past 2 years during COVID. And why African-American females aged 12 through 14 are also have high suicide rates at alarming rates over the past few years. And why Native Americans have the highest rates of depression and trauma because of colonization and forced removal from their land homes, from their homes. Structural humility will ask us to invite those questions. And then structural humility will require, after careful examination, for us all to come together, gather, and problem solve to dismantle structures and modes of operation designed to advantage cultures associated with whiteness while negating identity development, personal agency, and power systems among communities of color? Those are the type of questions that will be posed by structural humility. So those are the things I would like to share at this point, and thank you for your time and attention.
Thank you, Dr. Caldwell. So next up, we'll have Dr. Hairston.
All right, so thank you, Dr. Caldwell, for jumping us off there and getting the conversation started with a lot of good things for us to really think about and consider that will carry throughout this presentation. So just want to mention that I have nothing to disclose. Howard University is the institution that pays me, just in case the APA is checking on that. All right. So as we discussed, as we just heard from Dr. Caldwell, all racism is not overt. A lot of times you might hear people say, oh, well, I'm not racist. I don't do anything like that. I think the Ku Klux Klan is bad. I don't think that people should be lynched. So therefore, I'm not racist. Why do I have to hear about racism? It's not something that I live through or I perpetrate. Why do I have to hear about this? And it's important for us to know that all racism is not overt. It can be multi-level, it can be systemic, sometimes called institutional, sometimes called structural. And that is when different policies, cultural norms, and behaviors are allowed to continue to oppress certain groups. And then there's interpersonal. That's what people think about. Like, I don't commit anything racist overtly to anyone. I don't discriminate against people. So that's the one that people are more able to readily accept. And then also there's internalized. That's when you experience racism and you actually start to believe and sometimes act on these feelings as well. And included in all of these, and we can see all of these play out in bias. So bias is a part of all of these, and bias can be seen across all levels of racism. So what is bias? I think of as a general definition is that a bias is a preference towards a certain group, a certain entity, a certain thing. So it can be favorable or unfavorable. We traditionally think of it as something unfavorable when we're thinking about a bias. So explicit racial bias, this is something that people can identify and say that they know that this is something that they can easily say that that's something that's probably wrong. That's something that's conscious and it's acknowledged. A clinician acknowledges that they have a preference or an aversion to a certain racial or ethnic group. It can be suppressed or acted upon due to the societal norms, back to what I said about systems and structures, like whether or not this is a cultural norm that's accepted or a societal norm that's accepted in your system. And it can lead to racist acts that are purposeful. So that would be an example of a physician who refuses to care for Black patients or Latinx patients. So that one people are generally able to understand. And then I think that we're gonna have a speaker later who talks a little bit more about implicit racial bias. And these are usually unconscious associations with stereotypical attributes with a particular racial group. Similar to explicit bias, it can manifest as a preference or a negative association. Usually these come out in stressful, high-paced, high emotional toned situations that can lead to expression of behaviors that are consistent with implicit bias. And what I'm going to do is show you how a bias, be it explicit or implicit, we're going to talk about it in an implicit way, can really lead to structural oppression and systemic racism and can impact your patients and the people that you see and work with. So we didn't say that I happen to be a CL psychiatrist. I'm a consultation liaison psychiatrist. So I'm a very case-based teacher and learner, problem-based. I see it, I'm trying to figure out, get the data, and we'll discuss. So I'm going to give you a little case here. A case example, a clinical example of implicit bias, and see how this plays out. So we have a physician whose neighbor was robbed by an African-American male one day prior to her shift and working on an active acute inpatient unit. The physician also watches the nightly news where African-American males are often profiled as aggressive or violent. During the shift, an acutely agitated African-American male patient is having a crisis. the patient who is initially posturing and threatening, could be deemed aggressive, becomes calm after staff approach and is de-escalated. However, the physician feels threatened because of other things that are going on, some biases that she may have, and she insists that the patient should be restrained to manage the potential aggression, even though the patient is no longer aggressive, not showing any signs of aggression, and was easily de-escalated, and started on a high-dose antipsychotic, despite the patient's calm state and lack of consensus among staff. Now, that's how you see the interpersonal. There's a bias that's playing here. You see the physician is acting in this way towards the patient, right? So that's one way we're seeing that on a personal, person-to-person level. But how it becomes something systemic is when the physician teaches her residents that you use higher doses of antipsychotics in African-American men. Then those residents teach that to their interns. And then the interns spread this to their colleagues. And then other colleagues in the emergency room, in the emergency department say, oh, okay, this is how we must treat African-American males. They are more aggressive. And then it becomes accepted in this system. So it becomes a structural bias, a cultural norm that's accepted in this system, in this institution, that African-American males need higher doses of antipsychotics, they're more aggressive. And then you put these patients at risk for EPS and other side effects, because we know studies have shown us that African-American males are actually the most susceptible to having EPS symptoms when they are antipsychotic naive. So that is how a bias, an individual issue, can become a systemic issue or a structural issue or institutional, if you will. It's not just in psychiatry. I know I use psychiatry, but there's bias happens across medicine. We've seen it in studies. There's a 1999 study with our cardiology colleagues. It included MI treatment. So they gave clinicians, cardiologists, MDs, just like us, they gave them clinical scenarios. The only thing that they changed in these clinical scenarios is the exact same clinical scenario. The only thing that they changed was the race and gender of the patients. So it would be the same need, but they would just say, oh, instead of being a white man, this is an African-American woman. Same exact clinical picture. What they saw in this study was that time and time again, African-American women were not offered the next level, the next best step in treatment, which would be cardiac cath. They were either told that maybe they should follow up later, or that they should get some other type of treatment, but not this immediate intervention that was given when the patients were white males. So white males were offered this, Black males were offered this, and the last group that was not offered this frequently, time and time again, was African-American women. And we know that we have heard that African-American women, Black women, other marginalized women, vulnerable populations are not listened to by physicians. So there's something that we saw here. We also, many of you should know or have heard of the Hoffman study from 2016 in UVA, and that was the pain ratings where medical students and residents said that they thought that Black patients had experienced pain differently and had different nerve endings in their bodies. And of course, we're not just going to talk about other specialties. We have to own it also here in psychiatry. So Shakowski et al., there's a 2003 study and also a later one. If you're saying, okay, Dr. Hairston, these things are all over 15 years. They did again in, I believe, 2014 or 17. And that was where we looked at something that studies have been showing for quite some time, the overdiagnosis of schizophrenia in Black men. I don't know if any of you have seen this photo before, but this happens to be a 1974 Hal Doll advertisement. And you see this Black man who, I don't know, looks like a soul brother, a threatening James Brown-like figure. I don't know what this is supposed to be. And it said that this is the first choice in therapy. If you have a patient who is like this Black man, assaultive and belligerent, the answer is to give them an antipsychotic, which is Hal Doll, because this is how people who need Hal Doll look, like a Black man dressed in a leisure suit with, this is how they were depicting people who have schizophrenia. So an example of how biases lead to issues in psychiatry, treatment and diagnoses. The main one that you will hear about, this is just one because I only have 10 to 15 minutes, I'm going to try and keep it at 12, is the misdiagnosis of schizophrenia. Since the 1970s, researchers have found that African-American patients are overdiagnosed or misdiagnosed with schizophrenia. Their mood symptoms are underemphasized. They are not asked about depressive symptoms. And although the majority of epidemiological studies have shown that there's no difference in the prevalence of primary psychotic disorders, we see that there is consistently a higher rate of diagnosis for African-American males. So the national data shows that psychiatric hospital admissions have demonstrated that African Americans are 1.8, almost 2 times as likely as their white patients to be diagnosed with schizophrenia, and half as likely to be diagnosed with an affective disorder. Evidence demonstrates that these disparities are caused by multiple factors ranging from clinician bias during the interview and the formulation process to racial differences in patient population. So there's that. Another one that we can talk about or we can consider really mill over is missed trauma. So for those of you who treat children or young adult patient population, a lot of times racial bias affects the way that children and their behaviors are viewed and assessed. Racial and ethnic bias can lead to misdiagnosis of oppositional defiant disorder or conduct disorder through explicit and implicit mechanisms. Oftentimes, they're given these bad children or the bad kid diagnoses, and they miss trauma, they miss neglect, they miss mood disorders and anxiety in these children. And instead of asking, what is wrong with this child, as Alta Stewart says, you should be asking what happened to this child. So labeling a behavior without completely assessing for trauma is a gross error. And we also see it during treatment planning when clinicians are deciding what types of treatment patients are going to get, the services, the levels of care. There's often bias here that we see across psychiatric systems and treatment. So level of care, African-American patients are more likely to be treated for psychiatric illnesses involuntarily. They are more likely to be hospitalized, 4 times as likely as their white peers to be, when they are hospitalized, they're 4 times as likely as their white peers to be placed in seclusion and restrained. That goes back to what I said earlier about the perception that African Americans are aggressive and can be assaultive, back to that assaultive and belligerent ad for Hal Doll. Antipsychotics for African American patients, they're less likely to be given second generation antipsychotics and adjunctive medications, and long-acting injectables or depot medications are more frequently used in African-American patients. Down there, I happen to write a book chapter in Racism and Psychiatry about bias in treatment and assessment in a 2019 book. So we have lots of examples there. And I heard that you can just Google and find the book. Well, don't say that I said it. All right. How are we going to address this? I think later speakers will tell us more about it, but just as I can bridge a little bit for you, the ways that we first address bias and really attack the structural issues in psychiatry and medicine, period, is to ask tough questions. To ask tough questions and ask these questions with cultural humility in mind. You will never hear, and the students that I train, the residents that I train, they will never say, they should never say, if you ever interview them for anything, that they are culturally competent. We don't talk about cultural competency, we talk about cultural humility. And NIH defines cultural humility as a lifelong process of self-reflection and self-critique, whereby the individual not only learns about others' cultures, but one starts with an examination of his or her own beliefs and cultural identity. That means asking yourself, why do you believe this? What's going on with me? Why is this something that I've been acting on? Why is this something that is normal for me? Why is this culturally accepted for me? Cultural humility is distinct from cultural competency, because cultural competency usually centers whiteness and treats other groups as the other, so that you are understanding of the other culture, and it continues to marginalize these groups with saying, oh, I understand that culture, as if everyone in that culture is a monolith and is the same. Cultural humility requires historic awareness, and I think that we will hear a little bit more about this. It requires the understanding of where people have come from. It requires the understanding of history of people's families, but also of history of policies and previous experimentations in Black communities, previous intentional neglect of certain communities when it comes to medical care. And it really requires you to understand the policies that are in place. As Dr. Caldwell told us, it's not just, oh, we just think about it in one system. It's across all systems in the US, including the legal system, where we see a disparity in the treatment, disparity in the sentences that are given for crack versus powder cocaine. It's in the housing system, where we see laws that were purposely made to keep certain racial groups, Black people, from owning homes and obtaining home loans because of federal policies in certain neighborhoods. It's also affects our education system, where taxes inform how you pay for public education, and there's little value placed on many Black neighborhoods. So if there's little value placed on the housing there, they don't have enough tax money, and then therefore they do not have the same resources, as Dr. Caldwell told us, as other neighborhoods of different socioeconomic status. So I'm just gonna give you a little taste there about how biases affect this entire country, but especially us here in psychiatry when we think about assessment and diagnosis. Thank you for your time.
Thank you, Dr. Hairston. So next up we have Dr. Sarraf.
Make sure I'm off mute here. So I'm Kemia Sarraf, and I also have no conflicts to report here. I'm adjunct assistant professor at SIUS School of Medicine. I work there in the Office of Equity, Diversity, and Inclusion, and my official title, well, I won't tell you what the students call me. It's very nice, but it's a little sweary, actually. But what I was brought in to do was to work with our students, our residents, our learners, and honestly, our faculty as well, when critical incidents of bias come up, and really when trauma makes an appearance. And so I am there as a trauma mitigation specialist, and really enjoy the work, despite the fact that it's heavy and hard work. Enjoy the opportunity very much. And so I'm going to take us in a little different direction for a minute that I hope will weave some of the incredible information. I'm taking notes as fast as I can over here, because there's been such rich teaching that's happening. And I want to pull back the lens a little bit to begin with, just to talk very, very briefly for a couple of slides about the process of learning and this movement from what we would call unconscious incompetence. I don't know what I don't know, and I'm pretty comfortable over there because, hey, I don't know that I don't know it. So it's low energy state. It can feel very safe, into a place of conscious incompetence, on towards conscious competence, and then finally unconscious competence. And a way that I often like to illustrate it is with what we call the learning you, where things we're oblivious to stop. And then we move into this place where we become aware of how much we don't know and can become intensely uncomfortable. There's a very metabolically heavy state for the brain to exist in. There's a lot of work that goes into learning in this place. And then as we practice and we move on, we can come over into this space that we would call conscious competence. It's still effortful, but it's less anxiety provoking, it's less fear provoking. It starts to become second nature as we continue to work and move through it. And so when we ask people where they like to live on this learning you get a lot of different answers. I'm always surprised when colleagues or friends might mention that they want to spend 95% of their time up in conscious unconscious competence. To me, that sounds like a really boring place to hang out. I like to have that like sort of sharp learning edge to my life. There may be times in my life, though, that's not quite as true. So it's just important. The important thing to kind of keep in mind as we move through the remainder of what I'm going to talk about today is that when we are conscious of all the things that we don't know, that is a high energy, perhaps even anxious or anxiety provoking state. And it's not permanent. As we work at it, as we practice at it, we become better and we move along into a place where the stress declines, the effort declines, and finally things become second nature. And this is really, really important because one of the things that I have been called most about over the last couple of years is stress. People are stressed, our hospital staff is stressed, everyone is stressed, our patients are stressed, our students are stressed. Come and work with us on our stress, and come and work with us on our resilience. And that word in particular has become very, very heavily weaponized over the last couple of years. But what I want to draw attention to is that actually, as we all in this room know, stress is not bad. You know, stress is actually healthy and normal and important for healthy child development and movement. But stress exists on a continuum, from stress to toxic stress to trauma. And what we are seeing over the last several years is the compounding of this very, very high toxic stress onto people who have perhaps histories that include trauma, histories that include very, very high exposure to toxic stress over time. So we're going to talk about what happens with this continuum. Now, I do want to say that even toxic stress, even very high levels of stress, don't have to be bad necessarily. For many of us, medical school, doctorate programs, graduate school were times of toxic stress. And that can also be a stretch experience. It can also be muscle building for it. If the right effects are in place, if it's manageable. And what's manageable is very highly dependent. It depends on previous exposure. It depends on framing of those stressors. Have we seen them before? Have we overcome stress before? Do we have people around us who are scaffolding us and supporting us as we move through even very, very high stress? Do we have breaks and opportunities to rest and recharge as we move through? Do we have access? Do we have resources, internal resources, and importantly, external resources? How well resourced are we? How well scaffolded are we? And can we access the things that we need? If we can't, that learning use stops back in that place of anxiety and stress and sort of builds on itself. And then finally, what kind of learned skills and techniques do we have? You know, people who have a history of some adversity over their lifetime actually report better mental health and well-being outcomes than people on either end of the spectrum, those with high history of adversity and also people with no history of adversity. So those skills and techniques that we learn to overcome stress make that middle portion of this, that area where we look at, I'm not advancing very well here, that area where we look at toxic stress, that prolonged exposure, that makes it manageable. But when it's absent the protective supports, when it's inescapable, when it starts to harm growth and development, then we move along this continuum into this area that primes the system, that becomes embodied, that alters our underlying sense of safety and security, that harms and derails growth and development, and frankly, in children and also in adults. We talk a lot about the impact of adverse childhood experiences and how that alters health, how that alters mental health over a lifetime. But adulthood is not a trauma-free destination. It's not a toxic stress-free destination. In fact, for many of us, especially early adulthood, may be filled with trauma, some of them self-inflicted traumas, in fact. And so it's really important to note that ACEs, that the traumas we experience don't begin and end with ACEs. It's a wonderful, wonderful framework for us to look at and understand the incredible impact that trauma has on the body and on health. And I don't separate in this case, I don't separate mental health and physical health. It's health, but it isn't the entirety of the story because trauma lingers. And this stress trauma continuum that we're talking about becomes very problematic because right now we are living in times of unrelenting toxic stress. And what we know is that exposure matters. Exposure matters. In first year pharmacology, we learn that the dose makes the poison. And so what we're seeing over the last couple of years is this unrelenting exposure to toxic stress. I call it actually the tridemic of COVID-19, of violence, of racial violence, which is cumulative and compounding on centuries of racial violence and of isolation. And the isolation piece of this is very, very important because as much as we are hardwired for threat detection, we are also hardwired for connection. And it is that connection that allows the nervous system to settle. And this idea that we can be immersed in this type of environment in such an unrelenting, inescapable way, that our exposure can be this high, and to believe that anyone will remain untouched by it is as ridiculous as thinking we can walk through water and not get wet. And so what this gives us is as perhaps an expanded framework for understanding the multivariate ways that trauma come in and impact us. It can be exposure to an event or an environment. And it can be experienced as primary trauma, the trauma is happening to me, secondary trauma, I'm walking alongside someone who's experiencing that trauma, and vicarious trauma. And the impact of vicarious trauma on a system, on an individual, on a group, on a population, absolutely cannot be overstated. When we begin looking symptomatically at what shows up when people are experiencing the symptoms of embodied trauma, it is impossible to differentiate between traumas that are primary traumas and the impact of vicarious trauma on them. The dose matters a lot. And right now, many of us are experiencing a lot of all three of these. And it has this lasting effect. Trauma is very sticky. And so we talk about them. What are the types? Well, there's some of the ones that are well known, like abuse, emotional, physical, sexual. There's also institutional abuse, which has been touched on and talked about here, educational abuse. There's neglect of physical or emotional care, neglect in the terms of absence of connection. There's loss due to death or abandonment, separation. It can also be things like job loss again of connection, loss of sense of self and place in the world. And then we start talking about things like community and national and global traumas, violence. Racism is trauma. Poverty can be trauma, is not always, but it's certainly, its presence moves us along that stress trauma continuum towards trauma. War and natural disaster and pandemic. And then we have the systemic traumas, the historical and intergenerational and institutional codified traumas. And then finally, epigenetic trauma. And so if I were to walk up and ask 100 people on the street what they thought traumas were, they would give us sort of these things, these very defined and well-known definitions that we touched on earlier. But what we know now is that chronic exposure impacts our processing and our capacity, that it's how we experience an event that determines if it's traumatizing, and that what traumatizes one person may have little or no effect on another. And coming back around to this idea that trauma can be primary or secondary or tertiary or vicarious, what that takes us to is our capacity to limit our exposure to vicarious trauma. It's the one that we do have some control over. Those of you who, like me, like to doom scroll, there are opportunities to try in some ways to monitor, at the very least, notice what our exposure is and decrease it. And why this is important is because, as Resmaa Menachem really beautifully details in the book, My Grandmother's Hands, trauma can be anything that happens too much, too fast, too soon, too long, that is coupled with not enough of what should have happened that would have been resourcing. Why all of this matters so much from my perspective is that when working with students or colleagues or residents who are trying to move in and through these times, who are trying to learn in a very, very high stress environment, they are down in that area already of conscious incompetence, learning really hard material in really stressful situations. And then we begin piling the stress of the tridemic on top of that. And we have to remember that every single student, and particularly our minoritized students, are bringing with them an entire history that of institutionalized racism and harm, that it's very, very important that there is a sensitivity and awareness and understanding of the multivariate impact, the intersection of all of these different experiences and how they are being profoundly compounded by the times that we're living in. Slowing down, making space, allowing others to tell us the truth of their lived experience, holding time for the expression and unpacking of strong emotion. All of these things allow for students' nervous system to rest and for them to step back into their learning environment with greater confidence. So that scaffolding and that support is the biggest thing that we are trying to build and create, along with some recognition and some real understanding of the historical and lived nature of these times and how they impact our students. I see lots of deep breaths kind of happening there all at once. That was a whole lot. My apologies. I flew.
Thank you, Dr. Sarraf. And then our final speaker before we open it up to questions is Dr. Wills.
Dr. Wills, I can't hear you.
Dr. Wills, you're still showing us on mute.
Hello, okay.
There we go.
Okay, is it working now? Okay, let me go back to. Okay, good evening. I've enjoyed listening to everyone, and I've some of it was a nice refresher, and I learned a few things, and that's always positive. As a forensic psychiatrist, I'm always thinking about shades of gray. The reason I think about that is I gather the facts, I look at them, but then I have to look at other possibilities and nuances, because if I don't, I risk being biased or prejudicial, and that can impact the outcome of the case, but also it can expose me on cross-examination as I didn't do my homework. But on cross-examination, when someone says something that makes sense, whether I like it or not, it's incumbent upon me to acknowledge it. So I'd like to start this talk focusing on cultural humility. But before that, I'm going to go back to something Dr. Hairston said, because she said it in terms of black and white, and I want to expand that in terms of shades of gray. Cultural competence, there is something to be said about cultural competence, but what Dr. Hairston's saying is that there's inherent danger. And let me give you an example. I decided that I wanted to work at the Navajo Nation. The culture interested me. I wanted to learn more about it, et cetera. So I felt it was important for me to be informed about it. So I went and got some books, some videos, read, et cetera. Now, in terms of cultural competence, some people, and this is one of the criticisms, believe it's finite. But that finite nature is aspirational, because if you use it as a finite product or mindset or process, then I go to Navajo Nation and say, I know there is all there is to know about you people. And that's the danger. But if you use it to inform your cultural humility, then you go and you use what the slide shows as critical self-reflection, openness, non-judgment, curiosity. And as Comas Diaz and colleagues said, it's been shown to have benefits in treatment, such as strengthening the therapeutic alliance and improving outcomes, but it also increases our capacity to connect with each other as human beings. So I take that knowledge that I've derived, and I use that to pose questions so that I can learn more. So I've read about the sweat lodge, and that sounds like an interesting proposition. And the response was, it is. Let me tell you about the sweat lodge. And then we're going to set up time for you to see the sweat lodge. And we're going to do this, and it's going to be free, because you're going to deal with the real people. You're not going to pay $500 like you'd have to pay in Santa Fe. And then I come back the next morning, and they have a mini discussion about it. So what was your experience like? What were your thoughts, et cetera? So they are being humble in terms of my perspectives as a Black American to their sweat lodge, but I'm also using self-reflection during the whole process and experience to think about what it means for me, how it impacts them. And I learned a lot about their culture through that sweat lodge. For example, that they are docile people. And once, one of the things that one of the women pointed out, because it was they do it gender specific, was that she reminded the women in the sweat lodge that when our men go to war or go to the military and are trained to kill, that's a different mindset, because we are a docile people. And so when they come back, you have to take that into consideration in terms of your interpersonal relationships, their behaviors, et cetera. And remember, you may want them to be peaceful, but if they have something like PTSD, if they're traumatized, et cetera, then you have to be aware of that and act accordingly. So cultural humility is what we're using right now to reflect on things. These are the basic skills that we've learned in psychotherapy anyway. We all have them. It's just a matter of being cognizant of them and getting away from the managed care approaches that we are doing, paid by numbers, prescribed by each patient, but going back to those basic psychotherapy skills and being humble, thinking about why you do, as Dr. Hairston said, and not being judgmental. Okay, with that, I had to throw in a forensic slide, a forensic example, and in terms of barriers to judicial equity and the absence of structural humility, or cultural humility, and it shows bias. Caldwell, Hancock, and Hancock did a fascinating study in Philadelphia courts. They took 8 native speakers of what they described as African-American English, and they had them record their voices. And they had 27 court transcriptionists who reviewed those, they listened to the tapes and transcribed. And what they found was those 27 court transcriptionists had accuracy in sentences of 59.5%. The accuracy of words was 82.9%. who, what, where, and when were often transcribed incorrectly, and sentences were correctly paraphrased only 1/3 of the time, although that wasn't related to accuracy. So picture yourself as a person who speaks African-American English, and you go into the court system, and you say one thing and they interpret it as another, and you go up for appeal, and it's transcribed in a different way in the court transcription. It doesn't represent what you say. That can have a tremendous impact on the outcome of your case and your liberty interests. The level of sentencing, whether you're innocent or guilty, or in how you perceive things, or how you say, once you try to get appeal, they said, well, you said this, not that. And you're like, the system's against me. Well, sometimes that's true, because court reporters have to score 95% on the court reporter exam to get certification. The problem with that is whom they use as examples. Those recordings that they use are of judges, attorneys, and newscasters. They do not represent the average person going through the criminal justice system. And the transcriptionist said, we'd like more training in this. It's not that we want to mistranscribe, because in school they told us we should ask questions if it's not clear. But what they said is that in the courtroom, it's quietly discouraged. So I give this team credit for doing this study, and they're actually working on doing a study with native Spanish speakers. So we'll see what happens with that, but this is a problem. Okay, I want to move a little bit to bias in preschool education. There was a study done at Yale, and what they did was they had a preschool conference, and they had videos. They invited some of the preschool teachers in to observe some videos, and what they told them was that the video is going to show kids, preschoolers, with aberrant behavior. So they turned on the videos and they tracked the eyes of the preschool teachers, and what they found was disproportionately the teachers tracked the behavior of Black children, especially Black boys. And white teachers rated the aggression more severe than Black teachers. The interesting part of this whole experiment was that all of the behavior was age appropriately and developmentally appropriate. There was nothing there that showed aggressive behavior. So what is the implication for the family? You're a child psychiatrist and you come in, or you're a parent, you're an adult psychiatrist and you have a parent come in and they say, you know what, they're always picking on my boy, on my girl. And sometimes this is true, and it has nothing to do with the child's behavior. It has to do with the biases, the inherent internalized biases, the unconscious biases of the teachers. And we see how that dynamic can affect the relationship between the teacher and the parent, the teacher and the child's self-esteem and being singled out, et cetera. That can be a trigger for depression. We see this often in kids with ADHD, but these kids actually aren't doing anything and they're being singled out. But it also affects that parent-child dynamic. And that can have profound implications for the developmental experience of the child, and the perception of the efficacy of the parent being an authoritative, nurturing parent, because it's putting undue pressure on both of them. So what about medicine? Let's jump into here. Dr. Hairston went into some of this, and others spoke to some of the aspects of trauma and such. I'm going to move into the AMA because we have limited time. I just want you to know what the American Medical Association did. And this happened started in about June 2020, after the death of George Floyd and the civil unrest. And they declared that racism is a threat to public health. And they suggested that we create pathways to truth, hearing, healing, and reconciliation, and to advance equity in medicine and public health. Okay, in November 2020, they declared that race is a social construct, something that we've many of us have known for years and years, but the AMA had never said that. But here's the crux. They said it's distinct from ethnicity, genetic ancestry, or biology. In other words, race is not a biological determinant of health. And people are like, what do you mean race is not a biological determinant of health? It affects morbidity and mortality. Well, actually, it wasn't race. It was, and we'll get to that in a minute, it was the experience of racism. So they recommend that clinicians and researchers focus on genetics and biology, the experience of racism, and social determinants of health, which are informed by that experience of racism and those so targeted when describing risk factors for disease. And this is compelling. The experience of racism. It has to do with longevity based on zip codes, the experience of the community you live in, the experience of how you're treated. The person from Africa who comes over and develops malignant hypertension, and they're saying, wait a minute, none of my family has this. Why am I having this now that I've moved to America? It must be America. And the doctors are saying, you know what, this person is in denial. Well, maybe there's some truth to that. So let's look a little bit at this experience of racism in medicine. Here are some examples. When I chaired the APA's Presidential Task Force on Structural Racism throughout psychiatry, in August and September 2021, there was a Saturday, and I said, I get all the AMA headlines from all of the disciplines. And I said, well, let's look at structural racism and bias in those examples. And this is what I came up for that day. Well, first, before that, I'm going to talk about algorithms in healthcare. And this was actually October 2019, wherein it was in the news. Basically, a hospital system found out that its algorithm was defective. You have a person come into the emergency room with CHF, and the only difference between who got in and who got out with the same symptoms being equal was race. If the decision tree said, if the person's Black, send them home. If the person's white, admit them. So is that because of the programmer? Was the program told to do it? Was it done as a poor joke? Was it internal bias and unintentional? We don't know, but when you're punching numbers and data into these systems, you have to be cognizant of the potential for this. Then we've heard a lot about renal disease, and this has been going on for a while. Dorothy Roberts, who is a professor at UPenn, a professor of law, was a Robert Wood Johnson's health care scholar, and she wanted to understand why we use different estimated GFRs for Blacks and whites. And she traced it back to the 1920s or 1930s, and guess what? There was no evidence base for it. It was a case of Ipsy Dixit, because I say so. In other words, some professors said this was the case. And she went on a crusade to change this. And scientists also looked at it. And about maybe 3-4 years ago, slowly hospitals began to look into it. And about 18 months ago, I called my hospital on it, and it went to the top levels, and they said, well, you know, a lot of people have staked their careers on this, and we do factoring in blah, 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 blah. And so I told my chairman, he said, would you like me to go further? I said, not at this point. There'll be more research that's going to change this in due time. They're not ready for this conversation. Well, a month ago, they changed the parameters. When I went to see my doctor and had labs during my physical, she mentioned it too. So part of this is that they're finding new ways to calculate things, and Sue and others and colleagues actually published a paper in the New England Journal of Medicine in September 2021 about the use of cystatin C, where you can use that as calculating estimated GFRs while avoiding the negative consequences of current race-based approaches. Why is that important? Well, if you say that Blacks have an estimated GFR different than whites, then you're going to delay treatment to Blacks, and automatically when they get referred to the nephrologist, they are going to be at a more severe state of disease, which affects morbidity and mortality. And contrary to popular belief, when we prescribe lithium, those people who've been prescribing it for a long time say, yes, it will affect the kidney in due time. So this is very important to us. Not only that, but the longer it takes for you to get diagnosed and treated, the more likely you're going to have other tissue damage and concomitant effects related to the renal disease, which means when you apply for the transplantation list, they're going to say no. So you're more likely, if you're Black and have that rating, to be denied eligibility for renal transplant, which is another discriminatory practice. Let's move to cystic fibrosis. The carrier rate in whites is 1 in 29 and 1 in 65 in Blacks, but oftentimes people are taught in medical school that this is a white disease. Well, studies show that Blacks with cystic fibrosis, it takes 4 times of 4 years or more to make the diagnosis. And I've had 3, maybe 4 Blacks on my caseload who have cystic fibrosis, and they confirm this. And the impact on their lives and their relationships, some of them haven't been diagnosed until adulthood, but the kids, you're going in, children's services coming in, they're accusing the parents of neglect because the kid keeps coming in with pneumonia. And then all of a sudden, somebody blindly looks at an x-ray and says, who's the kid with CF? Speaking of blind x-rays, sometimes racism can work the other way and be harmful to whites. In about 2003, the Children's Hospital of Philadelphia did a study that was published in JAMA. And what happened was they looked at long bone fractures in Blacks and whites. And what they found was, given the same, I think they blinded them at one point, and they said, given the same x-ray, the demographics and it had an impact on whether or not the case was referred to children's services. So Black kids were disproportionately referred to children's services. And even when it was the x-ray was consistent with disease, with abuse, if you are a white child, you more likely to go home with your parents, nothing said. So that can be damaging too. The National Academy of Sciences study was in 2020, and Dr. Hairston mentioned about pain perception. And they did this with white people in the community, but also white medical students. And 1 in 2 medical students believe that based on their internalized biases, their unconscious biases that they brought into medical school, Blacks have a higher pain tolerance than whites. This has been shown consistently in terms of discrimination of pain meds in the emergency rooms, pain meds for all diseases, even kids with appendicitis. It's been shown that even when the pain is rated the same, a Black child would be given lower dosages of pain medicine than whites. Not only that, but it's worse if you're a non-English speaking person of Hispanic background. Actually, they said Latinx. Excuse me, not English proficient was the term that was used. And what they found is that kids of parents who spoke Spanish but were not English proficient were less likely to get or got fewer radiological studies in the emergency department. And by the time they went for their appendectomies, they were disproportionately more likely to have a ruptured appendix. They didn't come into the emergency room that way, but those biases play a role. In Cleveland, they show pedestrian motor vehicle fatalities also could be related to what's going on in communities, where they found that communities where there are people drive less, people have fewer resources, had higher rates of motor vehicle accident fatalities. So they're looking into that. And Dr. Hairston talked about schizophrenia. So let's move on to bias in burnout. This was a cohort study done by Dryby and colleagues, published in 2019, looked at the Maslow burnout injuries inventory, which is 2 questions to determine what you're, whether or not you're burned out. And then they also did a card sort to show implicit bias. That's that bias that exists, but you're not intentionally aware of it. So it's there and it can be shown in studies, et cetera. And then they looked at explicit bias. That's the biases. I don't like red shoes, so I will not wear them. The implicit bias is more like, Sally says that she's fair when admitting people into the nightclub, but for some reason, people wearing blue shirts are always at the back of the line, even if they have VIP passes. So that's the explicit versus the implicit. And they took over 3,000 non-Black second-year residents and found that stress levels were directly associated with implicit and explicit bias against their Black patients, their Black people, how they relate to Black people. And they bring that into the examination room and how they relate to you, how they, respond to you, et cetera. Third year, there's less stress. So at third year, there is less explicit bias. I can't stand Black people because they all X, Y, and Z. But the implicit bias, just like I said, the people end up at the back of the line, even though she says she's not biased, is still there. So that doesn't go away even when residents are not burned out. So let's talk a little bit about the experience of racism in psychiatry. I'm sorry. This is the another slide about the JAMA information. The NIMH showed that exposure to outdoor artificial light at night is associated with decreased sleep duration and an increased likelihood of a mood disorder in adolescents. Well, who has exposure to more artificial light? People in communities where there is less green space. Those environments are also more subjected to air pollution and global warming. Why is this important? Because decreased sleep duration and mood disorders have both been associated with suicide spectrum phenomena in adolescents. There also was the Finland birth cohort study that showed with 14,000 women, maternal antenatal corticosteroid treatment is associated with increased preterm birth and increased mental and behavioral disorders in children. Why is that important? Well, when you're in the polluted area and the area that's more subject to global warming, that marginalized community where there's more artificial light, you're also going to have more likely to have pulmonary disease in pregnant women. And this is one of my favorite studies. They looked at adult refugees in at disadvantaged Denmark neighborhoods. And this was a nice size study. Hammond had over 49,000 subjects. And what they randomly assigned refugees as they came into the country to these neighborhoods of various levels of disadvantage. Of course, they were not going to be in the most elite communities. But what they found was the level of neighborhood disadvantage was directly associated with cardiovascular risk, which goes back to your longevity being, or your life expectancy being associated with your zip code. And that's not limited to the US. Okay, so I'm going to end with this because I know we have a lot of discussion. People are going to have questions and we have speakers. This is a quote from Barack Obama. You can be completely right and you still are going to have to engage folks who disagree with you. So don't try to shut folks out. Don't try to shut them down, no matter how much you might disagree with them. And that's important because this goes back to cultural humility. If you shut down the conversation, you're never going to get people to buy in and expand their minds and grow. So we have to find different ways to engage people, no matter how mad you are or how right you believe you are. Thank you for your time.
Thank you. Thank you, Dr. Wills and Dr. Caldwell, Dr. Hairston, Dr. Sarraf. This was awesome. So we don't have too much time for questions at this point, but we've got a little time at least. We are going to stop the recording and not record the question and answer part, just in case that might make people more comfortable.